Welcome to another edition of American Healthcare 2021, Now What? A series of important conversation amongst prominent economists, actuaries, providers, and public figures highlighting the need for more informed decision-making to address the challenges and opportunities facing our healthcare system. Our first program examined the proposition that the American healthcare system, as currently configured, cannot consistently deliver affordable, quality healthcare equitably when and where needed. The second program focused on looking at the operational disconnects between the coverage and benefits being promised and the ability of the budgets, infrastructure, and managerial oversight available to deliver on what's been promised. The third program then looked at the role holistic analysis could play in improving our understanding of the complexity and reach of the healthcare system. And now this fourth discussion will focus on a closer look at a comparative assessment model capable of generating holistic analysis that can help decision makers and consumers in real time. The program will begin with a discussion between Mark Litto, FSA, retired Milliman principal, head of the Concerned Actuary Group's healthcare team and chairman of the Concerned Actuary Group, and Ronald Colby, former CEO of United Healthcare Insurance, a founding partner of Insurex, and also a member of the CAG Concerned Actuary Group healthcare team. Mr. Litto and Mr. Colby will then be joined by a very special guest, Tommy G. Thompson, who is currently serving as the president of the University of Wisconsin System. Mr. Thompson's resume also includes 14 years as Wisconsin's longest-serving governor, and 4 years as President Bush's Secretary of the United States Department of Health and Human Services from 2001 to 2004. Our last discussion made the point that improving healthcare policy decision-making would require more holistic analytical capacity, the ability to recognize and interpret interaction within the system, and to be able to inform decision makers in real time. The analytical tool we have developed is a comparative actuarial assessment model that addresses all of these needs. The CA2M contains market impact signal areas that capture activity, stimulation, and stress in each of 6 areas, including cost, coverage, access, health status, economy, and sustainability. It also contains coverage delivery mechanisms that capture activity, stimulation, and stress within each of the existing delivery mechanisms, including large group, small group, individual, Medicaid acute, Medicaid disabled, uninsured, Medicare, and other. Cross-referencing the market impact signals against the coverage delivery mechanisms produces 48 intersections, which allow for significantly more holistic analysis of the potential impact of proposed changes to the healthcare system. I asked Mark Litto to give us an overview of how they had put the model together.
We get to this model is we actually look backwards at the actual experience. We developed models for 1950 and 1992 and 2008 and 2017 and 2019. So you're trying to link all these items by looking backwards as to historically what happens, what's the credibility of the data, and then you use those to make projections as the system changes to reflect new system versus old system. So for example, if you change your coverage and you make it richer, what happens to utilization of services by the people? If you cut reimbursements to providers, as CMS often does in the programs to try to save money, what happens to the utilization of services? What happens to the number of providers that exist in those programs? If you create options in the exchanges, how do people change their behavior? How does this affect their health status if they don't have sufficient coverage or if they have too much coverage?
When you look back at costs, for example, what sort of patterns emerged? What data revealed those patterns? And how did the experience inform the model in terms then of assumptions and algorithms?
So you can look at the actual costs that emerge in the healthcare system using national health expenditure data and see, and relative to population, and see what happens to actual costs over time and how changes in the system impacted that. So what happened in the United States healthcare system in 1950, healthcare costs were 2% of GDP. Today, they're around 18%. They have gone up continually over this period of 70 or so years. And the question is, why has that happened? How does that relate to wage growth? So we look at all those patterns and we try to assess what's happened, not only just the cost, but what happened to all the other factors such as coverage, access to treatment, the health status of the population, the GDP output, and other factors related to that and sustainability of the system.
So you take a look over time and you go in and you say, what's causing this? Or do you simply look at it initially and say, well, what are the factors that could cause?
We are looking for cause and effect relationships exactly across a whole series of factors.
And how do you drill down to the point that you get to cause effects?
So what we do is we do an analysis where we hold all the factors constant except for one. So we start with the population factors and we have the age, gender of the population in markets. And then you move over to the health status. And when you move to health status, you hold the age, gender factors constant. Then the next factor is income and assets. So we hold age, gender, and health status. And then we do that for all the market factors, factor by factor, to try to match what's happening. And we see how the population is changing, whether it be income, health status, or age, gender by market. And then you go to market forces, things that you mentioned, like the coverage, utilization due to coverage changes, managed care levels, utilization changes due to managed care levels, reimbursement levels, and then provider availability, supply versus demand. So we have all those factors in, we do it one at a time, and we try to match over those periods to see what's happening given the changes in regulation or the environment.
Well, I look at the market signals that we've got up there. Cost and coverage are obviously clearly directly related to this healthcare process. The other two that strike me as being related to those two phenomena are access and health status. So let's start with that access question. And you suggested that part of what's going on in terms of what we're doing from a policy point of view is adversely affecting access for some people. So coverage should be going up, but access could actually be getting worse. Is that what you're suggesting?
Yes, that is what's happening. The process that's being followed, the intent is, of course, to give people better access to medical treatment. So it's not just having coverage, it's actually getting access to the care they need when they need it. But unfortunately, many of the types of reforms and changes we've been making have been having the unintended consequence of producing virtually the opposite. And the reason is we've had, as we talked about, numerous cost problems over time where healthcare costs have been accelerating faster than wage growth for a long period of time. And so the reaction to that very often is to cut reimbursements to providers or effectively give more subsidies to people or the employers so that it, in essence, seems to lower the cost of healthcare coverage. Now, it may lower the cost of coverage for the person, but the problem is it also is effectively a cut in the reimbursement to the provider.
So, at a high level, what you're depicting is a scenario where we are putting ever more people into a particular aspect of this system, particular component of the system, Medicaid, where reimbursement is quite low. You put a great number of people into this system, increasing demands in ways that Mark has described, and the infrastructure cannot be built quickly enough, and there's insufficient revenues from a system that reimburses at such a low level to fund such an infrastructure build to get back in balance.
And when you do that, you get a big gap between demand and supply. And that means that when people go to the doctor or they go to the emergency room, it becomes much more difficult to get an appointment to see whoever they need to see, whether that be a primary care physician, a specialist, whatever.
In 2020, the concerned actuaries beta tested the analytical and predictive capacity of their comparative actuarial assessment model, the CA2M, by modeling the projected impacts of the Affordable Care Act as enacted in 2010. I'd like you to talk a little bit about how these projections were arrived at. We've spent time talking about how the model was built and what you put into the categories. And I note that every time you present these findings, you make a point of stating that only data that was available in 2008 were used to make these projections. There will probably be cynics who will talk about things like reverse engineering and stuff to put it on the table. So I'd ask you to talk about the correlation between, or what you're saying when you say only data that was available in 2008 were used in this model to run this beta test. Let's start with that, and Ron, I'll let you go first.
Yeah, just quite straightforwardly, that's exactly how the particular beta test that you were describing was conducted. The model had been established by looking backward in time, as Mark has described, and then you want to make a projection of what could happen without knowledge of how it turns out. So to do this beta test, we put ourselves, in effect, back in the year 2008 and simply used data that would have been available had we been sitting there in 2008 wondering about these questions. What could happen if such a change is made or such a change is made? And fed the model data that would have been available to us at that time.
And to add to that, so in 2010, there were certain reforms that were made to the healthcare system. We talked about the Medicaid reform previously. There also was coverage of pre-existing conditions, along with restrictions on rating due to health status and age. And there were some other changes made. So the way we recognize that in the model is historically there have been other states, other countries that have made these types of reforms. And we went back and looked at the data. So for example, in 1993, New York put in a reform covering pre-existing conditions with a 12-month, what's called a 12-month look back, and did not allow the insurance companies to differentiate premiums based on age or health status at all. That's one example. New Jersey had a different reform. Other states, Vermont, Kentucky had different reforms. Their reforms like this were also found in Australia, in South Africa previously. So we look at all this data, and based on those types of changes made to those systems, we can make judgments of how the populations and the providers and other parts will react when you make these changes to the baseline. And then those algorithms pick up those new behaviors versus the old behaviors. And the difference is shown in the output that comes out of the model.
The following slides were first used at a presentation entitled A Better Mousetrap at the American Health Insurance Plan National Conference on Medicare, Medicaid, and Dual Eligibles. It was an online conference on September 14th, 2020. We have considerably more documentation than we have time, so let me focus the time we do have on giving you a feel for what the CA2M can do. This CA2M output grid I showed you earlier comes from a beta test of the model designed to determine what sort of value the CA2M might have provided had it been available to policy decision makers between 2008 and 2010 when they enacted the original Affordable Care Act, the ACA. The bar we set for ourselves was that to earn the trust of the elected officials and policymakers and the people they serve, CA2M projections must consistently over time prove to be within a reasonable range of accuracy. We believe that our collective experience with COVID-19 has underscored the need for reliable, accurate vetting of major policy proposals. Let me point out that as you look at these slides, the dark red lines is CA2 model estimates, and the gold lines are actual estimates or numbers. I'm happy to tell you that the model performed well. For example, it accurately projected the increased cost of Medicare and the cost of Medicaid. It forecast the increases in our out-of-pocket costs, flagged the growth of disproportionate coverage. It foresaw increases in benefit utilization and the soaring impact on governmental debt. It also indicated how the ACA might affect the cost of private healthcare markets. Jim, the model suggests that expanded coverage and cost actually adversely affected access for certain populations. Could you talk about how that came up?
So in a lot of the reforms, what we do is we have been expanding eligibility by, for instance, increasing the level of income that they qualify for Medicaid, but there's other things they can make the eligibility requirements more lenient to get into those programs. If you raise income or asset levels where people qualify, it brings in people that, while they still have low incomes, are quite a bit higher. Prior to ACA, people qualified state by state, and they could have incomes at only 20% of the federal poverty level up to 100%. And now they qualify up to 138%. So in some states, there's a pretty big jump. And what happened is some of the people go from too little coverage or inadequate to too much coverage.
Could I ask you and Ron to kind of chime in and explain what the criteria is for saying too much?
People focus all the time on the situations where there's no coverage or inadequate coverage. We understand those pretty well. When we say too much coverage, what we're really talking about is at a given income level, people do have the ability to participate themselves in the cost of their own health care through premiums and through cost-sharing mechanisms, such as co-payments. And if you take a situation where you remove that economic participation that a person could have given their income level, you create incentives possibly for overutilization. They have no skin in the game. So healthcare is essentially free or nearly so. And you can have a situation of overutilization. You can have situations of paying too much for a given type of care. So a system like that is very inefficient. It leads to higher costs, and it costs more to provide that coverage than would otherwise actually be necessary. So you do an analysis that focuses on cohorts of individuals at a given level of income or given range of income, and match the ability that that cohort of people would have to pay some amount of their own cost of healthcare out of their own pocket, given their income.
So the issue on access has a lot to do with the supply versus demand. And in the healthcare system, there's been a very substantial disconnect for a long time, in that we have been cutting reimbursements to providers, particularly under Medicaid and Medicare. And what happens is providers are not getting reimbursed a lot, so they cut their participation. People are getting large subsidies for the care and not paying. The utilization goes up. So you have an increase in demand. The supply does not keep up because you're cutting down on reimbursements and encouraging providers to either not work in those areas, retire early, or see fewer patients, at least in those areas of coverage. So you get this gap. And so people have the coverage, but they really have great difficulty finding a doctor or a facility to take care of them. You've created this tremendous surge in demand and restricted supply, and that creates a lot of disconnects in the system. And that carries over then to a lot of other areas, whether it be revenue, costs, extra need for subsidy.
The only thing that I would add is thinking through a bit of the longer term implications of what you just described. And so you talked about people now having more trouble getting appointments or getting timely appointments. Treatments go undelivered. People don't take care of their primary healthcare needs as well. Given enough time, that has implications for the health of a population. If health deteriorates, then productivity deteriorates. You get effects on the economy. You get effects on healthcare costs, as you've described. It's more expensive to treat something later in a disease process when it is more acute than earlier when you could spend less and take better care of the person. And then you have a question in the long run of sustainability of the system. This is not a recipe for having a long-term support of a system when it's costing more than it needs to. It's leading to these deleterious implications, and people are having trouble accessing the care that they expect.
I think you've done a really excellent job of describing the model. We'll have a discussion now with Governor Tommy G. Thompson, former governor of the state of Wisconsin, but also former secretary of the U.S. Department of Health and Social Services. And I think it would be helpful if we just talk briefly about why we want to talk to Governor Thompson and what it is we hope to learn here.
I would like to see the governor discuss two specific issues. First, the gap between supply and demand. In our prior analyses, we've seen that there's a shortage in number of doctors, shortage in nurses, a gap between in rural areas between supply and demand versus urban areas. The second area we'd like to see and discuss is subsidy versus need. We see some people are not getting sufficient subsidies to recognize the needs that they have. And we are also seeing that some people are getting subsidies far beyond their needs, which create serious problems.
Well, given Governor Thompson's experience throughout his career as governor and as head of Health and Human Services, he was there. And as policy was being made at the state and the federal level, and I'd love for him to understand a bit about the data we have, the model we have, and to guide us a little bit on how we might be able to apply that data and that model to healthcare decision making.
Governor, you have had an opportunity to interact with America's healthcare system from all sorts of different vantage points. You were a legislative leader in Wisconsin. You were governor of Wisconsin for 14 years. You were George W. Bush's Secretary of Health and Human Services. Given all of that, could you give us a brief overview of the types of healthcare issues that you experience and how you address them in your various roles?
That I come from a rural area. And as a legislature, I realize that rural areas across the country are not getting the proper healthcare system. You can't attract the doctors. You can't attract the necessary professionals. You have to travel a long distance, and you're pretty much left to your own devices on healthcare. So in regards to that, I introduced legislation and set up a program for family doctors and encourage those individuals to go into family medicine, to go into rural Wisconsin. And beyond that, then I set up the Physician's Assistance Program. Set up a course on PAs, physician's assistants, at the University of Wisconsin to help doctors and be able to use physician's assistants to be able to expand their coverage and their service across the state of Wisconsin. When I became governor, and I set up a program in Badger Care so that poor families were able to get health care coverage. I still think Badger Care may be the best low-income healthcare insurance program in the country. And then also at Governor, I set up Badger Family Care, which was to help the elderly. So it was also the first kind of a program in the country. Then I went on to become Secretary of Health and Human Services. And as you know, we passed the drug bill, Part D. If you remember correctly, we had the donut hole when it first came out. and it was passed on a partisan vote, but I did the lobbying for it, was on the floor of the Senate and House all night on both occasions, and was able to get that Part D, the drug care proposal passed. So I've been involved in healthcare all over the country.
Governor, given your extensive experience and your current position as president of the University of Wisconsin system, could you give us some examples of the grassroots challenges that you think the healthcare system is facing right now?
As I see it, we have huge shortages coming in this country. We don't have enough nurses. When I was Secretary of Health and Human Services, we were not getting enough young people to go into nursing. And now, because of the shortage and because nurses get paid very well compared to other professions, there's a lot of young people that want to go into nursing. The problem is that we do not have the masters and the PhD nurses that have the accreditation to become professors or instructors. And so we have a huge number of young people, well, young and middle-aged people that want to go into nursing. We just don't have the professors, assistant professors, or the instructors that can do the teaching. And most of our deans are in their late 50s and early 60s and going to be retiring. And I don't know how we're going to take care of the problem. That's where the Actuarial Association can be extremely helpful with your data showing that and the importance of it. And then you add to that the problems that we have with the medical professions. We have hardly any doctors going into general practice and family care, and because they don't get paid enough. And so doctors there's a huge short supply of that. General surgeons, you can't hardly hire or find a general surgeon in a hospital anymore. And there's a real need there. And that's where your actuarial data could be so extremely helpful to point this out. And then on top of that, we don't have enough doctors that'll go into the rural areas. And then there's hardly any, gerontology is just almost impossible to get enough gerontologists to go around and practice medicine. And as you know, the ACA is based upon really having more family docs, and we have a shortage of family docs and shortage of general surgeons, and definitely a shortage of gerontologists. And you got the disparity of location, and so you put that together, and so you got an access problem, you got a quality problem, you got an age problem, and all of this could be helped out by the actuarials association with the data. You need the data in order to fix the problem.
Your comments about demand and supply were right on. And you also referenced how the rural areas and the poor in many cases are being underserved. One of the things we've identified, and Jim's just sort of referenced to as well, is we call it subsidy versus need. We think there's a huge disconnect in that area. Mm-hmm. We're not getting certain groups enough subsidy, and other groups are getting subsidies that don't need it, which mm-hmm. creates a lot of overutilization, treatment, and waste and fraud. So in the context of your comments, can you talk about that a little bit as well?
Well, thank you for the question. I certainly can, because number one, you have a distribution problem across the country. You have a racial problem of adequate care. You got a poor versus a wealthy problem in regards to care. And you also have specialty problems in which some people live in areas that they have plenty of specialists and other people don't. And in other areas, you have just general practitioners that are so overloaded they can't handle it. And all of these things are problem areas. A lot of it's distribution, and a lot of it is the fact that nobody really wants to come and compromise and make some solutions. We need to bring these political parties together and be able to start looking at your data and solving the problems. we could sit down and we could take a look and use your data, and we could develop a program. Now, partisan politics has gotten so bitter and so parochial and so divisive that nobody talks. The Democrats want to go more to a government-controlled program. Republican wants to go left. But there's a big middle road there on equity and subsidy and delivery and so on, which you talked about. And some people are getting more than they need, and some are not getting nearly enough. But nobody will go across that marginal line, the divide, the continental divide, and reach an agreement. I told the Republicans, I said, sit down with the Democrats on ACA, on Obamacare. There's a lot of good in it, but it was not based upon cost. Nobody really looked at the cost. I said, you are Republicans. You're supposed to be fiscally responsible. Sit down and come in with the money situation and try and divide it. And a lot of you Republicans are from rural areas. Come in and be able to fix the geographical locations of ACA much better, and you'll be able to develop a bipartisan program. That's what America is thirsting for. That's what the data that you show is lacking. And it also is the data that shows the problems that I talked about are really there.
Certainly, you've captured our frustration, Governor. We have data. We've built the model that we've described a little bit here that can help translate that data into, what are the implications for some of these problems of a particular policy direction or another. And yet it doesn't seem like any elected officials are really in the market for data like this. They have a position that they favor, and this is more data than perhaps they're interested in. So I guess what I would wonder is there any other tactics or strategy? When I talk to just people and try to explain to them sort of what some of these issues are and what our analysis is available to help make decisions about these issues, everybody says the same thing. They said, yes, this is how decisions should get made. Yes, these are policies that should be considered. So any ideas for how could we gain more visibility for some of these questions, more support for this kind of analysis of policies that affect everybody's lives?
It takes effort to read all the data and make comprehensive decisions based upon data, not what you want the data to tell you. These are big issues, complex issues that need attention, and they need the cross-fertilization of both political parties to do it. We redistrict to make safe districts, and then we will not debate each other. We will not try and communicate. We will not try and come up together and discuss things. That's the position we are in America today. And I think it's terrible. I'm sad about it, but it's a realistic thing, and we got to change it.
Part of, I think, what drives us to believe not just that this needs to happen, but that there is a possibility here, is that the situation is so dire from a financial point of view that it is simply not sustainable. And so there's a constituency out there. They're in rural areas, they're in poor areas, they're in upper class neighborhoods, they're everywhere, who get the problem that this isn't working. Is where there is a real need and the clock is ticking, people with big ideas and some capacity may become in more demand than we have seen over the last few years. And so the premise is, if we can give people a tool that will help them see a clearer path, maybe we can get there. Is that a valid premise?
Of course it is, Jim, and you really hit on something that is so important. I mean, Medicare is going broke. Medicaid is already broke. You just appropriate more money for it each year. But Medicare is going broke. Social Security is going broke. What happens when they go broke? Social Security will keep going, but it'll be, for the first 5 years, we phase back to 80%. That's going to have a tremendous adverse impact on the economy.
Huh.
People are going to have to deal with it. So far, they won't look at it. Neither side will look at it. And that's too bad. Medicare is going to go broke before Social Security. That's the cornerstone of all the medical decisions. You know, Medicare is about 42%, but 18% of all medical decisions in the private area is made because of what Medicare says. So they copy, and that's going up. The total deficit, 21% of the GDP goes into healthcare, and that's going up every year. And we're going broke.
What you did is stroll across the landscape of American healthcare policy making over the last 25 years and conclude, as we have concluded, based on that data that you talk about, that there are serious disconnects here, okay? That you know, these things do not happen by accident. What would you say to them? Here are the things we've got to do on this healthcare thing. How do we got to make it sustainable? We got to do whatever. What are the things you would say to them?
First off, I would say we got a healthcare problem in America. We got some outstanding scientists, some great research, evidenced by the fact that we developed the vaccine in 12 months. So we got the capabilities, we got the brain power, but now we got to fix it. We don't have enough professionals in these categories. How do we do that? We don't have a good distribution of healthcare, proper healthcare around the country. How do we change it? How do we make people in the Delta area get good, adequate medical care? How do we do that in northern Wisconsin and northern Minnesota so that they have adequate medical care? Number three, how do we make sure the racial divide in America? How do we take care of the racial inequities and be able to develop a healthcare system for all people and be able to do it? How do we subsidize individuals to go in and become nurses and be able to become professors in order to be able to teach young people how to become nursing? And number five, I would say we have a monetary problem. How are we going to tax people correctly? And how are we going to spend money correctly? And let's sit down and figure out, some people are getting way too many subsidies. Some people are not getting enough. Let's be equitable. Let's sit down and really let's use the data.
We knew we had a tough job going into this interview. It's hard to not come out and say, job's probably even tougher than we thought it was going to be. And have been trying to figure out how to make it easier to explain and how to make it more meaningful for policymakers and their staffs to interact with what we can do. The first step in that process was the identification that you two put together of these four major areas. I'd ask the two of you to talk about, how did you get there? What made you think that those were the buckets that we should focus on?
In our analyses of the healthcare system since 1950 moving forward, we've seen four major disconnects. First, cost versus revenue, which is particularly exemplified in the deficits that the governments are running. Secondly, a gap between supply and demand that has continued to grow over time, particularly in the number of providers. Third, in the terms of subsidies provided by various programs such as Medicare and Medicaid, where some people are not receiving sufficient subsidies and others are receiving much too high of subsidies. And fourth, the difference in between short and long-term needs. Our programs tend to focus on short-term needs and push off problems to the long term. And whether those problems are deficits or inability to access treatment or other problems, they make our healthcare system unsustainable long term.
Right. We've heard about the holistic nature of the model and the analysis that we do, and the ability to use this holistic approach, looking across the healthcare system and considering the implications for a number of different variables. We've talked about that structure as we hope and we believe to be very useful in policy analysis in particular and decision making about healthcare. And these are four different configurations, four different ways of describing how some of those outputs could be understood. We're trying to find ways, useful ways of communicating the findings that we may make with this model in ways that policymakers and their staff could in fact find useful and understandable.
You've done 2 runs with the model. One was based upon the ACA, and we had all the data so we could take a look at how the model performed there. The second one, you made a decision that in order to test the model further and to refine the question of how we would present information and to policymakers in a fashion that would be useful to them, you had a conversation about how are we going to do that, and ultimately decided that the way to do it would be to take the Biden campaign, and I want to stress the word Biden campaign proposals for healthcare, and to at least run 1 or 2 of those options to try to understand what the model would project. Is that correct?
I think that's exactly correct, Jim. We were looking to have a different kind of a demonstration, one which truly was prospective, not one that we simply created a prospective opportunity in a historical demonstration, but one that truly was forward-looking. So we took major aspects of the campaign proposal put forth by the Biden campaign, and we wanted to model those and do a demonstration of what kinds of findings this model might turn up in an analysis of those proposals. One of the issues we faced right away is the proposals were they were defined at a pretty high level. And so we had to come up with many, many assumptions about what the details of such a proposal might look like in order to have enough definition to use the model to create this demonstration.
And in doing so, we picked one specific set of assumptions, but we've also identified other assumptions that could be made high and low, and certainly that's not all inclusive. And as we change those assumptions, of course, the results will move in one direction or another. But the purpose of the model, again, is to demonstrate the types of actions and interactions we would expect. And then as we make variations in the proposal, we could assess what happens with those types of changes.
So what have we done? What is the concerned actuary group, and specifically Mark Little and Ronald Colby, done in terms of how we plan to present this information, to have the model work for public policy makers? What have we done to address the concerns that we hear from Tommy Thompson, our own concerns in terms of the interest of legislators? What have we done to make this easy to use, easy to understand?
So we've identified 4 specific areas in terms of our work that we think it's important to bring forward for decision makers. Number 1 are the numbers. So we look at all the data, the history of what's happened in healthcare in our case from 1950 forward, and we use that data to not only establish a baseline across a number of variables, but also behavioral items that occur between all elements in the healthcare system. Then we take that information and we do analyses of cost, coverage, health status, access, economic implications, and long-term sustainability of the systems. With all that information, we then look at that in pieces and ascertain transparency of the system, or what's happening in various boxes by markets or other subsegments of that. And lastly, when we get all the interactions going on between these components, we can see consequences, some of which may be favorable and unfavorable. And of course, we're particularly concerned with unintended consequences.
Right, exactly. And we take that format and apply it and present findings in each of the four major areas that we've already discussed, that the model is helping to identify: supply versus demand, short-term versus long-term, subsidy versus need, and coverage versus access.
We identified the four big boxes, which are coverage, access, et cetera. And in each of those boxes, we've then done four more things. We give you the number, we give you the holistic analysis, we take a look at transparency, and we take a look at unintended consequences. We identify questions then, and you get a much clearer sense pretty quickly. If not all the information you'd like, at least places where you better go and take a look at it, either to refute what we're finding or to understand why, assuming that that wasn't a goal of your bill, why that particular box has popped up red rather than green.
CA2M is a tool. And so we do all these analyses to test ideas and the consequences thereof. But it's also important as we go forward with these systems, whatever's implemented, to manage them. So you compare actual results to those expected, and to the extent that results are less favorable or more favorable, you may want to make adjustments. So because everything in the healthcare system and the economy is dynamic, and things do not stay static for long. So you have to use this as a management tool to keep modifying your system to make it fit your objectives.
Does our model capture whether or not you have included management discipline?
Well, it provides the ability to do that, but management discipline means you're going to accumulate more data. You're going to test the hypotheses that you set out, just like in science. And then you ascertain whether our assumptions were reasonable or they were too high or too low. And that can mean that you need to adjust your system. And you should always be doing that, because in healthcare, for example, treatment protocols for cancer, for heart conditions, et cetera, change all the time. So, and that can cause changes in behavior.
This model does a variety of things, okay? It helps you design the bill, but it also is a clear, it rings a pretty clear bell about what you've been doing that doesn't work, okay?
Yes.
And here's those four platforms where these failures show up, okay? You have a problem between coverage and access because the management pieces weren't put together correctly. The performance wasn't observed. There wasn't a control cycle that went back and changed it, okay? So when we talk about these things, that dynamic is critical. Just so our viewers have some sense of what's coming next in this fifth program, where we're going to dig into the model suggests that if the Biden campaign proposal regarding a public option, as described and as we were able to hypothesize it, was enacted, that it would have a dramatic effect on the number of people covered in this country by governmental programs versus private sector insurance. Can you talk a little bit, put a little bit of meat on those bones, and then talk a little bit about the three categories that we talked about: holistic impact, transparency, and unintended consequences?
In a nutshell, without getting too far into the details, what our model predicts is that, in fact, under these proposals, and again, given the assumptions that we made about how the details would finally be put in place, a great number of people wind up covered in government programs. A greatly increased number of people are covered by government programs. And one of the things that has characterized the government programs to date, and we assume would continue to do so, is that they reimburse providers of healthcare at a much lower level than do commercial programs and private insurance. So you see, by moving a great number of people into these programs, which was intended as a mechanism for providing more coverage to more people, we also get the phenomenon of a constriction of revenue to the provider infrastructure in this country, creating more demand by people who have more coverage, richer coverage. At the same time, you're putting constraints on the growth of the ability of the supply side of the infrastructure to grow and create capacity to meet that increased demand.
And with that change, you also have to consider the other impacts such as health status. So if there are fewer providers, because reimbursement is lower, as Ron indicates, that also means some people are not going to be able to access treatment that they expect. That will mean poor population health status on average, which will carry over to the economy because people in poor health status will be less productive. So what happens is you may have lower cost in total, but you'll have, of course, the government's picking up a much bigger share of the cost. So the deficits won't necessarily get better and they could get worse. Meantime, you'll have less GDP, so less revenue coming in. So that's likely, therefore, to accelerate deficits and hurt sustainability. So, but all of these factors need to be considered at the same time in terms of the implications.